Good morning, Dr. Gullberg here, updating on diabetic foot infections. This is our infectious disease series. We see many diabetic foot infections in the hospital and clinic setting. 25% of all diabetics will develop diabetic foot infections, which is just a horrendous complication of this disease. So the risk factors for diabetic foot infections include peripheral neuropathy. Obviously, people with Charcot feet are at increased risk. People with poor compliance or who have elevated glycohemoglobins and peripheral vascular disease increase the risk for DFIs, as well as people who have trauma to their feet or pressure ulcerations, that type of thing. 2/3 of people who get diabetic foot infections get osteomyelitis. So one of the first things you have to do when you consult on these patients is see what the depth of the diabetic foot infection is. Is the joints involved? Is the bone involved? Just how deep does the soft tissue infection go? MRI now really is the gold standard to make the diagnosis of a deeper infection such as osteomyelitis. Of course, we used to use triple phase bone scans. At this juncture, MRI is really best. Very difficult though still when you've got a Charcot foot and you've got bone infection sometimes to tell the difference. Bacteriology wise, we usually see mixed flora. Beta strep, staph, MRSA tend to cause the cellulitis surrounding the wounds, but the ulcers themselves can be loaded with bacteria that come from the ground or the soil, including gram-negative rods like E. coli, Proteus, Pseudomonas, as well as anaerobes, which obviously add a lot of odor to these wounds. If there's necrotic tissue present or necrotic, or infected tissue or bone, all of this needs to be debrided either by surgery or by good physical therapists in order to enhance healing. Other treatment modalities include improving glycohemoglobins, taking good care of the skin if there's dyshidrosis or if there's tinea or eczema. Skin needs to be moisturized and treated. We need to augment the circulation. If the circulation's poor, these ulcers just continue to be a problem. So a good vascular surgeon or a cardiologist needs to be involved. We need to minimize edema. We need to minimize any pressure ulceration, so good podiatry is imperative. And of course, as I said, we have to remove necrotic tissue, and once we've got decent granulation tissue, we can consider a wound vac. Otherwise, broad spectrum IV antibiotics are usually indicated for at least 6 to 8 weeks. For an osteomyelitis, for a soft tissue infection, not that long, probably mostly just oral antibiotics. So this is give you some summary points on diabetic foot infections. Very common problem. You need to be aware of how to approach them. Thank you, Dr. Gullberg.